So what about our role, as doctors? Where do we fit into all of this? And I think hopefully, what you'll walk away from is you can ask some relevant questions right up front with respect to why somebody might be behaving the way they are, and really helping people to focus in on what they're concerned about. Paint the picture. Paint the primary symptom. There may be others that you have to deal with as well, but what are you most concerned about? Be specific. Not everybody, that you work with in residential care or acute care has been trained in P.I.E.C.E.S. So you kind of have to get a sense, if the person on the other end of the phone has some sense of what P.I.E.C.E.S might be, or if they've ever looked at the BPSD algorithm. We've been trying to for sure get the word out, so you can always check in to kind of see, because if you know you're talking to a P.I.E.C.E.S person, then you can go back to the 3 questions and start that very focused kind of discussion. You kind of want to know, particularly in residential care, but it's true here at Hillside Centre, it's true at Royal Inland Hospital. If this has been a problem that people have identified, do they have a behavioral support plan? You want to know, has the person on the other end of the phone, usually a nurse, do they know about a behavioral care plan? What is on paper to help deal with this situation? Because if they don't have that, then you're really cueing people to start thinking about this along the 3 lines and starting to pull all these pieces together. We are responsible for diagnosing and treating people, and we're responsible for looking for untreated medical problems, that geriatric sort of assessment that we need to bring to the table. So we have to keep that piece in mind when we're looking at somebody. And I can assure you that we miss hearing impairment because the batteries in the hearing aids do not work. And we miss, what else do we miss? We miss visual field deficits. A lot of people have had some kind of cerebrovascular accident, and so if you're not seeing out of the right side of your body, but I'm coming in to give care, that could be a bit of a surprise. That could generate some reaction in a verbal or physical way. That might mean that you need to orient the bed to the door differently if you're not seeing out of one side of your visual field. Right? So it's that kind of thing, and we need to remember that. It also leads us to have conversations about goals. What is the goal of trying to palliate this person's behavior? Is it comfort? Are they going down an end-of-life trajectory? So the other thing that we really need to look at is medication review, polypharmacy. Are people on medications for a clear indication? Do they actually need it? Right, so what do we see? Statins. Yes. Statins in a 92-year-old. Really? So maybe we could reflect on that, because nurses have to administer pills. Half the people they give pills to don't want to take pills or don't know how to take pills. So now you're crushing and you're mixing and doing all kinds of fun stuff with medication. That's a whole other book in and of itself. So that gets into the appropriate prescribing, particularly with BPSD, knowing which behavioral and psychological symptoms, responsive behaviors, whatever you want to call it, may respond to medication, and those that may not.
And paying attention to new meds.
Yes.
What has changed? Because often, you forget. I get a call in the middle of the night, I forget that I prescribed a new medication 2 weeks ago.
Right.
I remember that.
Yeah. Do you have any meds that kind of come to mind? Antibiotics? Benzos, yeah. So you have to think about all that kind of stuff. Yeah.
We've done lots of investigations for people who started on escitalopram without kind of realizing, oh, that's why they have diarrhea.
Right? Or maybe why they're not sleeping at night now, right? So exactly. So you got to think about your pharmacy, your polypharmacy and prescribing.
Which again, in the middle of the night, it's nice to have my 5Ds at my, so I remember, right? Because at night, I'm not going to remember all of it. But if I think of, delirium, drugs, disease, disability, and discomfort, I'm kind of covered, right, in terms of questions. So that's why P.I.E.C.E.S is just so gluing.
Right, so in that moment, that's the acronym that you really want to bring to mind. We also have to remember consent. The concept of a therapeutic trial in psychiatry is super important for many things. So you particularly see it with respect to major depressive disorder. So you have to know what a therapeutic dose is of an antidepressant. We see people on little mini tiny doses sometimes of antidepressants, and then because I deal with refractory depression a lot here, that it didn't work. And I'm looking at it going, well, you didn't prescribe enough of it. So you have to know what your target dose is for many things in medicine, right? You got to know. So in your personal formulary of antidepressants and antipsychotics, you kind of have to know where you're going as a final dose before you say it's not working. So what the time frame is, what your goals are, and then reassessing whether or not it's been effective. Has the person gotten better? Have they gotten side effects? Or have they reached a dose where there's no improvement? So you've got to keep that in mind with respect to many things in psychiatry. And then, for example, if people do get better with risperidone, which is labeled in Canada for severe aggression and psychosis in Alzheimer's disease, if it works for aggression, how long do you keep people on it? So there are people who will respond to it, they will get better, and then you need to decide, when do I take people off? And so for some folks with aggression, we'll say severe physical aggression in the context of Alzheimer's disease. If they respond to risperidone and they've been stable for 3 months, our recommendation is start tapering the medication, because a good percentage, over 50%, may not have that problem back again. Some people might. And one of the things that we are learning are people who score high on inventories like the Cohen-Mansfield Agitation Inventory, and we use the Neuropsychiatric Inventory nursing home version here at Hillside Center. And studies have actually shown that people that score high on the NPI, if you start taking them off their risperidone 4 months later, they're going to have a recurrence. So we're learning that there are these subgroups of folks, okay? But that's what we as physicians, that's our responsibility. It probably doesn't cover all of it, but it's a quick run through.